Thank you, Fiona, and good evening, everybody. And looking forward to presenting to you this evening on, I suppose my title is Building Running Robustness, given that there is a running injury theme to this, and maybe discussing some things you can do to minimize the risk of injury and to help to make yourselves more robust as runners, either yourselves if you're athletes or as coaches with your athletes. So basic outline of the webinar is we'll go through some of injury risk factors and overuse injury models, of what we think we know of how these overuse injuries occur, because most running injuries are overuse injuries. You can get the odd acute injury. We'll discuss some of the common running injuries and what we know about them. I'm going to give an overview of the biomechanical demands of running and discuss then strategies to build robustness and to prevent or minimize the risk of developing an injury. So I suppose the first thing to consider is that our bodies are designed to adapt. Every system in the body, whether it's our energy system, whether it's our hormonal system, nervous system, muscle tissue, and anything else, is designed to adapt. And there's a very old and a model that's kind of stood the test of time called the General Adaptation Syndrome by Hans Selye, a Hungarian sports scientist. And this applies to any sort of aspect of biology. And we've got a baseline. That could be a baseline level of fitness. That could be your tissue, whether it's muscle tissue, bone tissue, tendon tissue, or cartilage. And we've got the baseline. And if we want to change the baseline, we've got to give it some stress. So when we train, we apply stress to the body. And as that stress is applied, our baseline will temporarily drop because our system is fatigued, it's under stress, alarms go off, hence it's called the alarm phase. And once we give ourselves enough recovery time, we get a chance to recover, and our fitness level or our capacity will increase. So it is important to have that sufficient recovery time. And that recovery time, that window, is known as a resistance phase. So we're starting to become resistant to that stress that's applied. And our capacity goes up. It's called supercompensation. And we reach a new baseline level of fitness or tissue capacity and so on. However, if we don't adapt adequately or sufficiently, whether that's because we overload, the stress is too much at a moment in time, we haven't allowed enough time to recover, we're operating at a low level of capacity on that given day or week, or haven't factored in the accumulated load and fatigue over the preceding days or weeks and so on, we don't adapt, and the alarm phase, I suppose, extends a little bit further, and our ability to recover becomes compromised and takes that a little bit longer. And if we don't allow for that an adequate window and try to apply more load on while recovery hasn't been fully complete, then we're at risk of some sort of performance decrement or risk of injury or illness or some sort of negative adaptation. So this paper by Tim Gabbett was published early this year, and just a nice illustration of how we can apply that general adaptation syndrome model to tissue. And he's, I suppose, taken some of the best evidence that we know for different tissues like cartilage, bone, tendon, and muscle. And you'll see that there are different, depends on the stress applied, obviously, you'll see that there are different recovery windows for each tissue. So for cartilage, when we apply repetitive sort of impact loading, cartilage can recover quite quickly within 30 minutes after a loading bout. That could be hopping, that could be landing, something that's kind of short and intense. Obviously, the accumulated running is a little bit different, but cartilage is designed, it's compressible, deformable. It is designed to repair itself and recover in normal circumstances. Obviously, cartilage does break down over time, and as athletes and even non-athletes get older, other factors such as metabolic factors, inflammatory factors can impact the cartilage's ability to recover and adapt. And bone can also recover quite quickly after short bouts of high intensity loading. So doing something like hopping or skipping or even sprinting, the bone tissue can recover within 48 hours. Obviously, during extended running periods, that can take a lot longer. Tendon, normally when we apply high intensity loading to a tendon, whether it's like plyometric exercises or sprinting or something of high intensity nature, it does take 48 hours or so to recover properly. And then if we apply high intensity loading to a muscle, particularly fast eccentric contraction, so eccentric is when the muscle fibers lengthen under tension, that does take, you get DOMS afterwards if you're not accustomed to it, and that can take up to 72 hours or more to recover. So again, it's important to keep that in mind. Different tissues take different time frames to recover and adapt. So essentially, when an injury happens, that tissue fails to adapt for some reason. And usually there's a mismatch between load applied to the tissue and the tissue's capacity to handle and adapt to that load. And I suppose load and capacity can mean different things. So again, this is quite a busy flow chart, but if we just work through it, on the left, we've got capacity. And if you look in the top left, that's your tissue capacity at the start of a training session or a given week. And that can be influenced by your previous training, how many years of training you have behind you, or even that given season, how many weeks of good, solid, consistent training you have behind you, your previous injury history, your diet, your sleep, your genetic factors, and the time between training sessions, or whether you've recovered adequately between your previous high intensity or high volume or high load training session. And when we're fatigued, that our tissue capacity can temporarily reduce if we do a hard session or if we accumulate a number of high demanding sessions over a period of time, that tissue capacity can reduce temporarily. And on the right hand side, if you look at load, there's different, I suppose, factors involved here. There's the load per stride, that's the force going through the body, and at an internal level, the force going through the tissue. And that can be influenced by speed, duration, and also the terrain you're running on, whether it's hilly ground, flat ground, and uneven surfaces versus solid surfaces. And then there's a load distribution per stride, because when we put load through the body, different tissues can experience different stresses, and that can vary from person to person. So someone's anatomy and body shape can differ from someone else, and that can influence where that load goes. Someone's running mechanics and style can also impact where the load goes throughout the body. Also, running shoes, different running shoes, different shoe types can have different impacts on different people. Whether it's your kind of heavy or more foamy type shoes versus your more minimalist type shoes, and also surface. So soft surfaces can vary where the load goes. Hard surfaces maybe less so. But again, not that one surface is good or bad. It's what you're accustomed to. And if you change footwear or change your habitual running surfaces, and you try to do the same training load, that can, I suppose, change how the stress is applied to the body, and that can be a bit of a risk factor if you're in a fatigue state doing that. And then I suppose when we look at that load, how it adds up, the number of strides in a given session, and also the tissue load per stride, and then how that accumulates over the session or over the week or training cycle. And essentially, when we're in a fatigue state, if we go back on the left, our capacity is lower, and we have a high cumulative load built up, and the tissue capacity is exceeded, and then we're at a high risk of a running injury. And I suppose we've also got to factor in the non-training stressors, because it's one thing, stressing the body and recovering properly, but also other non-training stressors can impact the body's capacity or the tissue's capacity at a moment in time. So if we take a typical day for a typical athlete, and if we assume that you dedicate 2 hours to your training in a day, you work or study for 8 hours. You might have a 1 hour round trip commute to work or to university or to school if you're a younger athlete. You might have some social activities, or if you're a parent like myself, you might have your kids' activities in the evening that could take up to 2 hours. You might sleep for 6 to 8 hours, and then you might have 3 hours there to play with for free time. So I guess, we think about the training time, but we often don't factor in the other stressors, the other time, the other 22 hours in the day. And that could have an impact on how you are able to recover and adapt to a training stress or a training stimulus on a given day or a given week. So if your work is stressful, or if you're a student coming up to exam time, that's an extra stress in the body that can temporarily reduce your capacity to handle training, delay your recovery time, and if you don't allow for that in your training, that can predispose you to injury. If you get poor quality sleep, so it's not so much how long you sleep, but it's the quality of that sleep. If you're lying in bed for 10 hours, but you only get about 4 hours of quality sleep, that's not great. Whereas if you go to bed for 6 or 7 hours, and 6 hours of that is good quality sleep, well, that's good. So again, most people probably need on average 6 to 8 or even 9 hours of sleep, but the quality of that sleep is quite important. And also how you manage stress, whether it's stress in the work environment, stress in your education environment, stress at home, and other things that can also elevate your injury risk if it's not managed carefully. So most systematic reviews looking at common distance running injuries have pretty much similar findings, and this is one by Peter Francis back in 2018. And the first image here looks at the site of injuries, and you'll see on there that the knee is the most common site of injury. Again, you can have different injury on the knee. Most common is patellofemoral pain syndrome, which is injury to the patellofemoral joint, but you can also have other knee pathologies such as IT band syndrome, patellotendinopathy, a meniscal tear, and so on. Other injuries are at the shank area, which is like your shin area and calf. So that could be like medial tibial stress syndrome. Often referred to as shin splints, which is a bit of an umbrella term, not one I like to use, but anyway, that's neither here nor there. Or even calf injuries and Achilles injuries. And then your foot and ankle area, ankle sprains, plantar fasciitis or plantar fasciopathy, metatarsal stress fractures, other bony stress fractures of the foot. And again, some of these are broken down. So again, patellofemoral pain syndrome is the most common injury diagnosed from this review. Achilles tendinopathy comes in second. Medial tibial stress syndrome, plantar fasciitis, iliotibial band syndrome, and so on. Calf strains, meniscal injuries, stress fractures. But the main thing from this is that 2/3 of running injuries occur from the knee down. So there's probably a message in that. And if we do a basic needs analysis for running, because when you look at most strength training programs and advice for running, people focus a lot on the glutes, the core, and all the rest, and probably neglect the muscles lower down that are quite important. And one study done in 2012 using musculoskeletal modeling determined that at around steady state running speed, which is around lactate threshold pace for most people, the calf muscles, the gastrocnemius muscles and the soleus, are the biggest force producers. They produce forces of around 8 times body weight, so quite large. Next in line are the quads, and then the hamstrings, the glutes, and the hip flexors. So the calf muscles are the big players when we're running, or even when we're jogging. And if you look at some of the chronic running injury sites, particularly the joints and around the knee and the lower limb area, if you take the external ground reaction force going through the body, when we're jogging, that's around twice body weight. When we're running slow to steady, that's around 4 times body weight. When someone's sprinting, that's about 6 times body weight. That's the external force going through the body. And if you look at the ankle, the contact force at the ankle joint, so think of that like almost like a suction pump at the ankle. So that kind of bone-on-bone contact, which is cushioned by cartilage and synovial lining around the bones and the articular surfaces, that's around 10 to 14 times body weight. And the force going through the Achilles tendon as it stretches is about 6 to 8 times body weight at kind of typical steady state running speeds. The knee joint contact force is around 7 to 11 times body weight, and the hip joint contact force are 7 to 11 times body weight as well. So a lot of forces, a lot of stress going to those common injury areas. And I suppose the question is, how are we prepared to handle those stresses over and over again? And if we look at some of the common running gait features associated with running injuries, this study by Chris Bramah in University of Salford in Manchester took a cohort of runners who had different lower limb injuries and look at some of the common features compared to those who were not injured. And you see on the left in a side view, you see someone who overstrides, so lands a little bit more on the rear foot, and the shin angle is a bit more negative or angled, and the foot is a little bit further in front of the body and a slight forward lean compared to the image B, where someone lands slightly more midfoot, more of a vertical shin, the foot a little bit closer to the body, and a more upright torso. And then if you look at rear view, on the far right, you'll see in image A, the athlete has what we call a contralateral pelvic drop. So when the right leg is supporting them, their left hip or pelvis drops or tilts a little bit. And you see the right knee twisting in, and you'll see a lot more rotation. You can see more of the toes on the foot from behind. So a lot more rotational forces going through the body there. Compared to the athlete in image B, who has a more horizontal pelvic line, has a less twisted in looking knee or thigh. And if you look from their ankle up to their hip, it's a lot more vertical compared to the athlete on the left in A, who's got a lot more where the knee sits a little bit more deviated in medially from their ankle and their hip. Now, there are people who run with some of those negative features who don't get injured. So, biomechanics is one thing, strength is another thing as well. But the key thing here is you look at all relevant factors that might load the body and also influence the body's capacity to handle that load. And for athletes who are more at risk, we try and influence those factors. As I said, if someone is a world-class runner, looks like the athlete in A in both those images, and they're not injured, they're operating at a high level, you mightn't change those mechanics too much because that might come at risks. Because if we change someone's mechanics, we're shifting load from one structure to somewhere else. So again, there's got to be good logic to do that. If someone has a recurrent injuries, they run with those mechanics and those loading patterns are relevant to the injury, obviously then we will try and influence that. So again, it's a little bit of common sense and logic. So again, some of these features that are seen are associated with patellofemoral pain syndrome, medial tibial stress syndrome, Achilles tendinopathy, and IT band syndrome. And a follow-up study in a different cohort of athletes found similar running features with people who've had previous calf muscle strain injuries. So if we kind of look at the calf muscle, which I've kind of emphasized quite a lot, and again, I don't want to overplay one muscle group in particular, but they are for long distance runners, they're actually quite they're quite relevant muscles. And they're quite big muscles as well. So for most people, you know, if you look at some from behind, you'll see the superficial calf muscles, which is the lateral gastric muscles, muscle head, the LG, as illustrated on that image, and the medial gastrocnemius muscles, MG. And then the deeper muscles, which is not very visible, is the soleus muscle, which is the biggest of the three muscles. So your calf muscles comprise of three muscles. Those three muscles fuse to form the Achilles tendon. And as I said, that the most dominant lower limb muscles are during slow to moderate speed running. And at around lactic threshold pace, which is like marathon speed or upper end of someone's zone 2, they operate around 85% of their maximal force capacity, whereas the quads might operate at around 65% of their maximal force capacity at that speed, and maybe the glutes and the hamstrings and quads, or sorry, glutes and hamstrings and hip flexors might operate more at 40 to 50% of the maximal capacity. And obviously those lateral muscles, those glutes and hamstrings and hip flexors, their force output will increase quite exponentially at sprinting speed. But at jogging speeds, they're operating at a lower capacity of their maximal force. And those calf muscles are packed with a lot more short fibers, mainly slow twitch, which enables high force output and efficiency. So a lot of force is spread across a lot of fibers, and they're not designed to contract fast or to lengthen and shorten that much. So they can be quite efficient. And they're slow twitch, so they can recover very quickly in a normal, healthy muscle. But it's also important that the calf muscles has got a good Achilles tendon so that it enables the muscles to contract efficiently. So if we go through some of our common injuries, and Achilles tendinopathy, I suppose, is probably the second most common reported injury among distance runners. And if we look at the image on the left, a healthy tendon has got that sort of very organized collagen structure. So you've got collagen molecules that make up collagen fibrils. Collagen fibrils make up collagen fibers. Bundles of fibers are called fascicles, and then the tendon is made up of bundles of fascicles. In between those collagen fibers, you've got cells called tenocytes, which help to regulate the tendon's homeostasis. So it allows it to maintain its properties and enables it to adapt. Or when the load is too much or hasn't got the ability to adapt to that load, those tenocytes can become overactive and cause the tendon tissue to break down. So see an example at the bottom of a tendinopathy where you've got a less organized collagen structure. You've got a bigger population of those tenocyte cells. They lose their shape. They become a lot more rounded as opposed to kind of more spindle shape. You get a lot more blood vessels and sprouting of nerve endings into the core of the tendon, which don't normally reside there in a healthy tendon. They normally lie in the periphery. So you see an example on the right of an ultrasound image of someone with a tendinopathy. The top of the image, I'm not sure if you can see my cursor, that's the skin side. The bottom of it is the top of your Kager's fat pad, which is like a triangle between your heel bone and your calf muscles. And where my cursor is, if you can see it, that's the bottom of your soleus muscle. So that area there is your mid portion. That's the most common site of Achilles tendinopathy. Yes, you can get a tendinopathy at the heel insertion, but what you see is a kind of a swelling of the tendon. So a normal tendon has about 4 millimeters of thickness when you look at it side on. But a pathological tendon with a tendinopathy that can actually double or even treble in some cases. So this example here actually has a thickness of 12 millimeters. Normal healthy tissue has like gray sort of strands that are quite continuous or look continuous. And then you see the tendinopathy region has kind of a dark area where you've got breakdown of collagen fibers. You've got an increase or an accumulation of water molecules. So the best way to describe this is like a healthy tendon looks like a packet of dry spaghetti. And with a tendinopathy, it's like having a packet of dry spaghetti with a wet patch in it, where those spaghetti strands become more thick and kind of gooey and puffy. So that's probably the best way to describe analogy to use for a tendinopathy. So you get a breakdown in collagen structure in that region, extra water molecules. That region is less tolerable to load going through it. And when you have a tendinopathy, it can impact how the calf muscles, the structure and the function of the calf muscles. So you can the calf muscles the fibers can shorten, that even one head of the calf muscles, oftentimes with a tendinopathy, it can be the lateral gastrocnemius muscle can shrink and can waste. And the fibers from the tendon fibers from that muscle can detension. And that can alter, I suppose, how the calf muscles are loaded. And that can predispose an athlete to recurrent injuries or even a subsequent calf strain. But I suppose there's more things than training that influence the tendon health. So, obviously someone's muscle strength and capacity is quite important. So again, how the muscle and tendon muscles, so the three muscles and the tendon coordinate, the mechanical properties of the tendon, how elastic or not elastic they are, and the capacity of the calf muscles. So that's important for tendon health. Training load and physical activity levels. Tendons like routine. So when the load applied or the increasing load is too much for the tendon to adapt to in a moment in time, again, it can trigger a negative reaction from the cells and cause collagen tissue to break down and for a tendinopathy to occur. And then age, obviously, older people can reduce some of their tendon properties can reduce. Certain medications like certain antibiotics, steroids, statins can influence tendon health in a negative way. Biopsychosocial factors. So, when you got a sore tendon and you're stressed and you're worried about it, that can amplify the pain response. And especially if you've got kinesiophobia, you're afraid to do something in case it makes it worse. And other systemic health conditions such as metabolic disorders, if you're predisposed to diabetes or other metabolic disorders, for females, hormonal fluctuations, menstrual cycle can impact tendon health, and certain autoimmune conditions like rheumatoid arthritis or other, I suppose, arthropathy conditions can also impact tendon health because it can trigger or fuel an irregular inflammatory response that can predispose someone to a tendinopathy or slow down the tendon's ability to recover and adapt. Calf strains are quite common as well. Oftentimes there's a gradual onset, especially in distance running. So sometimes you can get that sort of that kind of quick, kind of feeling like a dagger going through to the calf. So your more superficial calf strains, like the bottom of the medial gastroc, that can feel like that can be a sudden onset. You can feel it there and then. Sometimes with a soleus strain, it can be a gradual onset. You wake up the following day and you feel like you got a tight calf, and after I'll just warm it up and stretch it and foam roll it and hope for the best. Doesn't often work like that. So I'm always a little bit cagey when someone comes in and say they got a tight calf and it's been going on for a few days, and the point where they're struggling to run. You can't just work that out. So yeah, I would be kind of suspicious of a calf strain, and I would definitely try and get an MRI scan, especially for the soleus, because you won't pick it up on ultrasound easily. Even the most skilled sonographer, you can't fully rule out a soleus strain with ultrasound. So whereas you can with a medial gastroc strain. So an MRI scan is the recommended go-to to properly diagnose a calf strain, especially those deeper muscles. So older athletes are a bit more predisposed. Those who have had a previous lower limb injury, such as a previous calf strain, a previous Achilles tendinopathy, or a previous ankle strain, can have a higher risk of a calf strain or a recurrent calf strain. So if you develop a tight calf and it's gone on for a few days, I would assume it's a strain until proven otherwise by an MRI scan, because otherwise those days can become weeks and those weeks become months, and you're in the vicious cycle of trying to train, breaking down again, trying to train again, breaking down again, and lacking that bit of consistency. Some bone stress injury. So again, I suppose bone stress injuries are kind of operate along a spectrum. So you can have like say for the medial tibia, you can have like a reaction or an irritation or an inflammatory response around the periosteal area, which is where the muscles sort of anchor to the bone. And it's quite an innervated area where you get you have a lot of sensory nerves, and that can amplify the pain response, even though it mightn't look too bad in an MRI scan, because you got muscles sort of tractioning off that periosteum. Then you can have some bone stress, so the outer layer of the bone that becomes irritated, and you get some bone edema, and I suppose a low grade sort of stress response, not quite a stress fracture, but then you can move up through the grades. Then when you get a proper fracture line, then that's when you're in a lot of trouble. So basically, you got a breakdown of bone tissue, which is a normal response to training, and an inability of that tissue to sort of replenish or to repair itself on demand. And that process could be going on for weeks or months, not necessarily one session. Certain bones have a higher risk and need to be managed very, very carefully compared to other areas. So if you've got a bone stress injury to the medial tibia, again, the prognosis is quite favorable. That there's lower risk. If you got a bone stress injury to the fibula or the lateral ankle area, again, the prognosis is fairly favorable because of the bone's anatomy and geometry. The shaft of the femur, again, the risk is quite low of any complications. The same around the pelvis, same around the calcaneus, and the diaphysis, so a certain region of the second to fourth metatarsals. And the high risk areas are the neck of the femur, the front of the tibia, the medial malleolus or the medial ankle, the talus, which is like in your ankle, that kind of floating bone in the ankle that only doesn't have any muscle attachments, it has ligament attachments, so it doesn't get much blood supply, and the risk of a talus stress fracture that's not managed carefully, you can get avascular necrosis, which is definitely something you don't want to be at risk for. Navicular also can be quite a complicated one as well. And again, there's also a risk of, I suppose, non-fusion of the fracture and a risk of a necrosis, which is like a dying of the cells, and also certain regions of the fifth metatarsal, and the base of the second metatarsal and the sesamoids of the big toe. Again, they're got to be managed carefully if you have a diagnosis of a stress fracture in those areas. And certain factors that impact how load is applied to the bones is biomechanical factors, so ground reaction forces, your body shape and alignment, your running mechanics, training factors, so the duration, frequency of training sessions, the recovery windows, intensity and speed, your muscle strength and endurance. So again, the muscles around bones act like struts to keep the bone, to kind of control the loading going through the bone, because even though the bone it seems like a hard structure, it is quite pliable. So the bone is trying to bend or deform when there's load going through it, and those muscles help to buffer some of that. So if we're lacking muscle strength, the bone gets stressed a lot more. So again, the calf muscles and particularly your tib post and your peroneal muscles are quite important for the tibia and fibula respectively. Your foot intrinsic muscles are quite important for your metatarsals and navicular bone and so on. The training surfaces and terrain, and again, it's not that one surface is good or bad, it's when you try to adapt to a different surfaces while doing the same training load is an extra stress in the body, and the same comes to footwear. There's no right or wrong shoes that you can sort of apply across the board. Everyone responds differently to the same shoes. But if you change your footwear, don't allow a proper habituation period and do your normal training, that's an extra stress in the body. The muscles are going to get tired trying to adapt to that, and that can increase bone loading or loading in any other tissue. And other intrinsic factors, that can influence bone's ability to handle load, or genetics, diet and nutrition. So especially if you're depleted for long periods of time, the bone metabolism will slow down. Calcium and vitamin D is also important for bone metabolism. Hormonal status is also important, particularly for females, who are of menstruation age. Your physical activity history. So again, the more training you have in the bank, and more consistent training you have in the bank, the more robust you are to weather storms and to handle training load. If you have a low bone mineral density and risk of osteoporosis, that's going to be a complication that can influence bone's ability to recover and adapt. And again, certain medications can also weaken the bone and impair its ability to adapt. So some of the common strength assessments we do in the clinic, we'd measure calf peak torque or peak strength, usually on our isokinetic dynamometer, and we would do it at a speed of 30 degrees a second. So you're pushing out with the foot. We also pull back in to work to measure shin strength, but typical strength measures we look for recreational sports person being able to produce torque, peak torque so torque is like rotational force or leverage force, 130% body weight or 1.3 times body weight. For a sub-elite athlete, 1.5 times body weight, and for an elite sports person, somewhere upwards of 170% body weight to twice body weight. Sometimes we might do a seated calf isometric strength test to get a measure of soleus peak force, and again, we're looking for 1.5 to twice body weight of peak force. And also looking at calf endurance. There's one thing measuring peak strength, also calf capacity. So how many reps they can do to failure or to fatigue. So again, on a small 10-degree incline board, being able to do good quality calf raises, and when they get tired, we stop them and count the reps. So minimal 20 reps for a recreational sports person, maybe who's of middle to older age, 25 for your average person who's of middle age, maybe plays sport recreationally, and 30 reps for an e-sports person. And sometimes we might delve a little bit deeper and maybe measure EMG, which is like the I suppose the electrical activity of a muscle and the ability of the muscle to activate and see what the pattern is between different muscles. And sometimes we also use ultrasound to measure muscle architecture. If I see a suspicion of muscle weightage, measure muscle fiber length, and also measure tendon strain as the calf muscle contracts doing calf raises. And so it would profile someone based on this kind of quadrant, where you on the vertical axis is measure of your peak strength on the isokinetic strength test. So again, the cutoff being 150% body weight, and on the horizontal axis, how many good calf raises they can do through full range, with 25 reps being the cutoff. So if someone's in the bottom left, they're in a poor state, they got poor endurance, poor force, maybe at a high risk of injury, certainly not doing their performance any favors either. So we want to get them in that top right-hand corner where they got good force and good endurance. And so we also measure plyometric abilities, the ability to hop and rebound, doing it vertically and horizontally. So an example here of a double leg drop jump. So we measure their contact time and their flight, or their jump height, on a force plate. To do a double and single leg. In some cases, you might do a horizontal single leg horizontal rebound as well, and maybe measure repeated hops to see what they're like when they're hopping in a more of a cyclical pattern. And we want to see how high they can rebound or jump, or how long they can, if it's horizontal movement, how far they can jump, with a constraint on contact time. So we don't want to spend too long on the ground. So for a recreational sports person, we might say under 0.35 of a second, or a third of a second. For a sub-elite sports person, under 0.3 of a second. For an elite sports person, maybe 0.25 of a second. For more of a distance runner, for someone who's more middle distance, maybe under 0.2 of a second or close to it. And we see how high they can jump or how far they can rebound, while being under those contact time targets. So to develop calf strength, we would ideally get someone to the point where they can do calf raises on a Smith machine or a leg press. Obviously, not everyone can start with that. They might have to maybe start with a dumbbell, or even in some cases, if the baseline is poor or at a low level, start with bodyweight calf raises. But ideally, the calf muscles, they are strong. They're big force producers. If someone can do, single leg calf raises dynamically with good control, working into a little bit of a calf stretch and out of it, get the heels slightly above the level of the block, and maybe to get up to the point where they can do at least half or 60% of their body weight of external load in the Smith machine. And then, for more advanced calf loading for the more experienced athlete, on a leg press, be able to hold or push twice body weight of external load on the frame. So if it's a horizontal leg press or the plate's slightly above the body, all the load is external. I don't have my own body weight to overcome, so I have to load it up quite a lot. And be able to do repeated 5 to 6 second holds at about twice body weight or even more. And for the tendon to adapt, it needs load, and it also needs strain. So strain is like how much the tendon deforms. So when the calf muscles contract when I'm doing a calf raise, there's a little bit of a stretch in the tendon, and that sort of stretch activates the cells, and there's a bit of tension and I suppose sliding between the collagen fibers, and that activates the cells and can trigger a positive response if it's done in an appropriate way. And normally a tendon responds positively if the strain is between 4.5 to 6.5%. It can also perhaps adapt positively if the strain is a little bit more than that, up to 9.5%. If it goes beyond that, then and it's done and the tendon is not in a good, I suppose, starting point. If you do a lot of load where the strain is in double digits and the tendon hasn't got good elastic properties and the calf muscles are weak, it can predispose the tendon to injury. And the same if you rest a tendon and don't expose it to sufficient strain, the tendon will just break down and it becomes catabolic and its threshold lowers. So it takes a lot less for it to get sore or to develop an injury. And I suppose when we're rehabbing an Achilles tendon, a lot of people kind of focus on the calf raises and they're trying to get back running and then they get injured again, but they haven't exposed themselves to some of the movements that actually replicate the demands of running, like hopping and jumping and so on. So if you look at this table or graph that was done in a study a few years ago, they looked at common sort of calf exercises and hopping and jumping exercises and kind of matched it against the demands of walking and running. So if you look at walking there in the yellow bar, you'll see that it's one thing, I suppose, quantifying the force going through the tendon. The other thing is actually the rate of loading, so that the speed that the force is applied to it. So again, most of your calf exercises, they're important, but they're slow movements. And again, that's fine, but the tendon also needs to be exposed to fast movements that apply a fast stretch to the tendon. And if you look at running, you're looking at, for a slow run, you're talking of, loading rates of like 60 body weights per second. So if you're just doing calf work, you're only getting about, for a typical calf raise, find one here, single leg calf raise, you're probably talking about 15 body weights per second. So yes, that's important to adapt the tendon, but to prepare it for running, it's probably not enough on its own. So when you're doing some hops, especially double leg forward hops, single leg forward hops and drop jumps, you're getting loading rates of more than 60 body weights per second. So I always try to expose the tendon to a little bit more than it needs, so it's able to handle the demands of running. So again, typical plyometric training exercises, we might start with double leg poker hops and just try and get good smooth patterns, aim for a flat foot contact. Most people think they have to land on their toes when they're hopping, but the tendon prefers more of a flat foot contact. It's a more favorite way of loading the tendon. And then been exposing it to single leg hops, especially if you want to get back running at a decent level. You want to be able to take that load on one leg and be able to handle that. And then hopping forward, which is probably the highest loading rate on the tendon. So it's really important we try and tick those boxes. That's an important link between rehab and getting back running. And it's also important, I suppose, to address the kinetic chain. So, being able to squat or deadlift, do some sort of a whole body exercise. And again, not everyone's going to start with a heavy squat. This is kind of, your more well-trained athletes who are experienced, be able to squat 1.5 times body weight for a few reps. If you are going that heavy, again, just have your safety mechanisms in place, have your safety pins out, be comfortable sitting back on the heel. Should always finish a squat if you're doing, say, 4 to 6 reps, be able to finish their set with the ability to do 2 more reps if you had to. But for someone who is not experienced in the gym, they can just do a simple goblet squat. If they're comfortable sitting back on the heels, great. So I'm just going to let this play and push up fast. Again, the bottom of the squat, we want torso angle and shin angle to be parallel or as close as possible. Sitting back on the heels, knees not coming too far in front of the toes. And that's just a nice way to spread the load around the lower limbs. Make sure that glutes and hamstrings are doing the fair share as well as the quads. And if someone is not comfortable sitting back on the heels, they can use a box or a chair. So put that, you can see the stool behind, they can sit back on that and aim to tip the chair and then back up again. And then also maybe some single leg strength as well is important. So doing step ups, lunges, or even an example here of a Bulgarian split squat. Load one leg at a time. And again, just at the bottom of the bottom position, make sure we've got good alignment. Let this play. So control going down. If I just pause it there, shin angle, torso should be fairly parallel. Back knee should be sort of in line with the hips and shoulders. So again, just getting your stance length right and be explosive coming up. Okay, so again, aside from injury, there are, obviously performance benefits from strength training, and especially if you haven't got a massive background of strength training, if you introduce it at the right time and the right way, there is a carryover to performance. And one of the most common ways of measuring, I suppose, a response to strength training is measuring someone's running economy, which is how efficient you are at utilizing oxygen at a certain speed. So, plyometric training has been shown to have, over, say, 12 to 14 weeks has been shown to have a 4% improvement in running economy. Heavy and explosive strength training. So some of the examples I gave in the previous slide of doing heavy squats or doing something explosive improves running economy and time trial performance in 2 studies. And again, there's plenty more out there. And particularly the calf. I know I keep going on with the calf and the tendon, but doing increasing calf strength and improving the elastic properties of the tendon has also been shown to have a 4% improvement in running economy. So to put that into context, we know that some of those modern advanced running shoes with the special foam and the carbon fiber plates, on average, across the people who have been studies, has been shown to have a 4% improvement in running economy. People will spend 300 euros or thereabouts to try and get those benefits. But again, if you're doing strength work as well, you're kind of covering all bases. And you may get, doesn't mean guarantee that you get 4% improvement in running economy, but you may get some benefits if you haven't got a huge baseline already, if it's done in the right way and factored into your week carefully. So just a couple of sum up slides here. It's important to, if someone's rehabbing, it's important to build tissue capacity, build strength, and then, have a phase of building power and reactive strength with our plyometrics. Build the training capacity needed for your event. So if you're, a middle to longest runner, again, being able to do back into your long runs and, an appropriate number of interval or tempo running sessions before you're race ready. So again, it's important to work through those steps in that sequence, depending on the injury it is, and that kind of model can be applied to most injuries. So to sum up, how to be a robust athlete or to build that robustness, we want to try and give the body a chance to adapt. So a gradual increase in training load, not trying to accumulate too much too soon. And especially training for a marathon, people can often go into like a 3 or 4 month marathon training block off a low baseline and they accumulate a lot in 2 or 3 months. And that elevates the injury risk. Not allowing sufficient recovery time between sessions. So if you're trying to squeeze in into a session on a Tuesday and a Thursday and a long run on a Saturday, if you've got a busy week, that might be enough time to recover. So you may need to, I suppose, adjust it to your needs. Having a strength training program. And again, strong people will still get injured. It doesn't give you license to be careless with other things, but if you're doing a strength training program that's appropriate to your level of training and your needs, along with doing everything else right, it's certainly going to go a long way towards making you robust and build the tissue capacity needed and to be able to weather the storms in terms of training load increases and so on. Quality of sleep, and again, that's I suppose if you look at the one thing that's going to influence recovery most is quality of sleep. That's where most of the repair happens. Nutrition as well, so again, getting good fuel in at the right time, and making sure you're hitting your calorie needs on a day where you've got high energy expenditure. And also, if you're trying to build tissue capacity, making sure you're hitting your protein needs. And also allowing or managing non-training stressors and not overlooking that. And I suppose the most important thing is consistency. So the more consistent you are training with minimal gaps in your training in your training weeks, the more robust you will be And I suppose from a performance point of view and an injury point of view, that's going to stand to you. So hope you found it useful. Happy to take some questions.